everybody. Is this working? I don't hear the echo. Okay. I thank you all for coming. I wanted just a couple of housekeeping things. The restrooms are out the door and to the right if you need those. Let's see. I want to remind everybody to silence your cell phones, but keep on tweeting, and to tweet using the hashtag TXIZ14. And remember that our summit goal is to empower immunization stakeholders, you all, and arm them with information and tools to help them champion immunizations throughout Texas. And on a personal note, I'd like to just introduce Dr. Atkinson as sort of my role model. I do immunization answers for the organization I work for, Kelsey-Seybold Clinic, and my goal for this group is that you all feel like you can be the immunization answer person for your organizations, that you learn the tools and the resources to go to be able to answer those many questions that come up when people are out in the field doing the immunizations and run across unusual circumstances. Dr. Atkinson, of course, is the author of the Pink Book and the original answer man at CDC at NIP Info, both the telephone line and the email questions, and has served at CDC and now at the Immunization Action Coalition as a resource for all of us, and I'm sure he needs no further introduction than that. So I'm going to have a microphone, and so if you want to ask a question, if you raise a hand, I'll bring the microphone around. If you don't have questions, I have a handful of them, so.
I will answer the first question about how you can be a resource. And if there's one document that you need to be very familiar with, in fact, one that will answer the questions we used to get on, that I used to answer on NIP Info, and I answered a lot, and the ones that we still get on a daily basis at the Immunization Action Coalition, I would say about half of those, at least half of those, can be answered by the general recommendations on immunization. That's probably the single. It's a very unique document. I assume that most of you are familiar with it. It's published roughly every 5 years, and it addresses issues that are sort of cross borders with vaccines. Most of the other publications by the Advisory Committee on Immunization Practices are vaccine specific. The general recommendations go into timing and spacing and intervals and violations and repeat doses and storage and handling and vaccine administration and vaccine safety and contraindications and all those things. And at least 50% of the questions that we receive on a daily basis could be answered. And we reference the general recommendations specifically. So if you want to have one place and be the standout person in your group and be able to answer almost all the questions, you all have the general recommendations, but read through it. Another one, by the way, the current one was published in 2011. It's one of the few standing committees, standing working groups at ACIP that flu, influenza schedules, and general recommendations all never stop. Most of the other working groups, subcommittees have finite starts and stops. General recommendations is an ongoing challenge, and like flu and the schedules. And so they voted on the first half of it. It's done. There's so many pieces. It's so big. There's so many things in it that it essentially gets presented, some part of it, at every ACIP meeting. Now, back up, the Advisory Committee on Immunization Practices is a group of basically volunteers, non-public, non-federal government employees who are nominated by the Secretary of Health and agree to serve on this committee for 4 years. They come down to Atlanta 3 times a year, February, June, and October, and they have been doing that now for 50 years. And plus a lot of conference calls and a lot of other things. But there is some component of the general recommendations that is presented and discussed at virtually every meeting of the ACIP. They voted on the first half of what will probably be the 2015 or 2016, depending on clearance version. So there's a new one that's almost done and will hopefully be published within the next year. So watch for that. It won't have a lot of radical changes, but there's always a lot of good new information. And literally that one document, if you're very familiar with it, can answer at least half. If the questions we receive at IAC are representative and generally can answer half the questions that we get. So anybody who has something, just go right ahead. We have no schedule, no slides, no prepared comments.
Thanks, Hi. There's a new pneumococcal conjugate 13-valent recommendation, I think, now for 65 years in age and older. Routinely, they get 1 dose. If someone 19 years of age and older has some type of medical condition such as sickle cell or whatever, it's recommended that they get one now, earlier than age 65. When they turn 65, is there any revaccination with the PCV13, or is it a one-time adult dose?
The current recommendations, as I interpret them, it's a one-time lifetime dose. Once you've had a dose of Prevnar of PCV13, that basically does it. Now, pneumococcal polysaccharide is a different thing. That's something that you would get another dose of if you received one because of a high-risk condition before age 65. Once 5 years is over, you would get a second dose. And once you have received a dose at or after age 65, that's the last dose you receive. So that's another common question that we get that's not in the general recommendations. 1 dose on or after 65 and you're finished. 1 dose of pneumococcal conjugate vaccine and you're finished, based on the current recommendations. And there needs to be about a year to separate those 2 vaccines, whichever one is given first. Easy way to remember. If they got their PCV13 first, you wait a year before giving them their polysaccharide, and vice versa. Here's one thing you need to know that is not in the recommendations, and this has been discussed now at a couple meetings. CMS, Medicare, currently, based on their current, you're going to encounter this, and be aware of this trap, that CMS's current rule is that they will reimburse for a single dose of pneumococcal vaccine for people 65 years of age and older. That is an issue because now there are 2 doses of pneumococcal vaccine recommended for people at age 65 and older. But the rule has not changed with Medicare, which means that for all of those millions of people and all of your patients who you've been due diligence and have given them their pneumococcal polysaccharide vaccine when they were 65, technically CMS will not pay for a dose of Prevnar. Likewise, but if you give them the Prevnar first, then they will perhaps refuse or deny a claim for a dose of pneumococcal polysaccharide vaccine a year from now. Now, be aware that this is a major issue for all of those people 65 and older that you're going to vaccinate with both vaccines, and CMS has promised, has made a pledge that they will immediately start to look at this issue and hope to have a revision of their rule by, wait for it, 2016. 2016, CMS says they hope, that's the earliest that they would be able to actually, because it's a big deal to revise a rule for Medicare. So be aware that they are talking about this, but at the moment, if a person has already had CMS Medicare reimbursement for 1 dose of pneumococcal vaccine, whichever one it is, they are likely not to be reimbursed for the second dose or have the provider reimburse for it.
Does that mean you should give Prevnar as the first dose because it's more expensive?
That would certainly follow, wouldn't it? And plus, immunologically, it's probably beneficial to do it that way. That giving the conjugate vaccine first probably gives a good prime for the immune system. So yes, if the person is naive, that they've not received any pneumococcal vaccine, it would certainly be advantageous to give the pneumococcal conjugate vaccine first. Plus, remember, it's about a year. You won't give them their pneumococcal polysaccharide for a year. So maybe by then, Medicaid's rules will be different, and they will, in fact, reimburse for both. But you need to be careful about this, and my main concern is all the people that you've already given Pneumovax to. Because if you call them in, it's been 2 years, you call them in, give them a dose of Prevnar, and it gets denied, there's going to be a lot of people who are upset. So be careful, and I don't know how to tell you how to deal with that, but some people will be willing to pay for it and tell them, well, there's a chance that Medicare won't pay for this because you've already had your 1 dose and Medicare paid for that, and they're working on the rules now. Or you could just kind of bide your time for a year and hope that Medicare fixes their rules soon. But that was a big deal, and the ACIP, they brought it up and kind of pressed the CMS representative to deal with that issue as soon as possible.
So in adults, it's a year between the doses, but in kids, it's 8 weeks for some kids. And can you
And
kind of
actually for
explain
high
that?
risk, and actually for high risk individuals, for people who are asplenic, for instance, the recommendation is an 8-week interval. So the year between the doses is basically for people 65 and older. For high risk people, that would be people without a spleen, people who are immunosuppressed, people, those are the big ones. It's actually an 8-week cochlear implant, CSF leaks. It's basically an 8-week interval between, because you really want to get them as well immunized as quickly as possible. So PCV 13 first, 8-week interval, polysaccharide. And the year, to be honest with you, I was even on that work group. I still don't entirely understand the timing that was the year. Where exactly did this year come from? Actually, it's 6 to 12 months from PCV to pneumococcal polysaccharide. From pneumococcal polysaccharide to PCV, it's a year. So they not only use different units of time, they have different intervals, and I'm frankly not exactly sure where those intervals, how they were derived, but that's what was in the final recommendation. So just remember, basically a year between them. That'll make it easier.
I just wanted to clarify, if you have not received one over 65 and they're on Medicare, you would suggest giving the PCV 13?
Yes. Why? Because number one, it's immunologically advantageous. To give the conjugate vaccine first primes the immune system and probably leads to a better response from the Pneumovax. Plus, the reality is, as Dr. Hinman pointed, it's considerably more expensive. So that's the expensive dose. Get CMS to pay for that first, and then again, you're going to wait a year, and hopefully by the time a year comes around, they still need the 23-valent polysaccharide, but a year needs to pass, and hopefully by then CMS will have changed their rule.
So I'm going to ask one on Tdap, a kind of related question. So Tdap in someone who had either, encephalopathic reaction to whole cell DTP as a child, and now they're an adult and they've got a grandkid or someone that they want to protect, or someone who had, a colleague of mine had a joint pain and serious reaction to a tetanus dose in the late 60s. Not sure whether that was toxoid or what that was, but a reaction. Are they okay to get a Tdap?
Yeah, all those dire contraindications for DTAP, based on really our old experience with DTP, the whole cell vaccine, the encephalopathy and all those things, are really not applicable to Tdap. So yes, if a person had, we hear about that all the time. There's those folks are now getting their parents now, those kids who might have had DTaP, because you haven't used whole cell DTP now for nearly 20 years. It's been replaced by DTAP. So yes, all those contraindications and reasons that people that interrupted their dose of DTP, rightly or wrongly, back 20 years ago or more, those folks should in fact receive a dose of Tdap. Really the only it actually is brachial neuritis has been associated with tetanus toxoid. Like one guy got it twice, I think, in Australia or something. That's a precaution. And really allergy is, we're back to your allergic reaction. Somebody who had a serious allergic reaction to a previous dose, you need to be very careful. But just as having said that, a lot of people believe that they had something happen to them, particularly older folks, maybe in their 60s and 70s, who got a dose of tetanus vaccine back 30 or 40 years ago, and the doctor said, never get this again because you're allergic to it. And they believe, rightly or wrongly, that they are allergic to horse serum. Horse serum, just to let you know, there is not now, nor has there ever been, equine antibodies or protein in tetanus toxoid. There was tetanus hyperimmune globulin that was available in the early 60s and before, that some people got before there was a human immune globulin for tetanus, and that was used in the 50s and before, actually from about 1914 up until the early 60s. So that's been long gone, but there's never been any horse serum in tetanus toxoid. So don't let the horse serum allergy throw you if you hear that from somebody, because there isn't any in it.
All right.
Since we're on the pertussis topic, both Tdap brands that are currently utilized were licensed back in 2005 or available in 2005. We're coming up on the 10-year mark. We know that pertussis immunity wanes. And where do we stand as it relates to our booster dose for Tdap for adults?
I'm still, even though I retired 2 years ago, I'm still participating in the pertussis work group, mainly because I wanted to see how this was going to play out. And I can tell you that first for the general, with the exception of pregnant women, of course, who were now vaccinating every third trimester of every pregnancy, for the general population who are not pregnant in the third trimester, there is absolutely no interest at ACIP for recommending a booster dose, even though we are, as you rightly pointed out, we're approaching the 10-year anniversary, and all of us early adopters are now probably not even immune to pertussis anymore, seeing how the immunity probably wanes after 5 to 7 years. So and the reason for this is because of, number one, because neither of the vaccines is approved for more than one dose. That might be resolved, that might be fixed soon. And also because of the modeling. The modeling that's been done does not suggest that a substantial amount of pertussis can be prevented with a second dose recommendation, and the cost of doing it. And it turns out that economists now have a lot of clout at ACIP. It's now required that basically any policy be subject to a cost-benefit analysis, and it turns out that it would be extraordinarily expensive, and there's serious questions about how much additional pertussis could be prevented with a second dose for the general population. So it comes down to, what about all you high-risk people who are out there being exposed to coughing folks all the time? Is there not some subset of the population that might deserve a second dose, namely healthcare providers? And that's been discussed almost ad nauseum in the work group meetings, and it's looking now like the official posture of the work group, the subcommittee for pertussis, is not going to recommend a second a revaccination dose for healthcare providers because of a lot of the same reasons, because of lack of approval, because of cost, and also a reality thing. Those of you who deal with infection control or employee health know that we still recommend the same post-exposure prophylaxis in an exposed healthcare provider, whether or not they have been vaccinated, and that would probably be the same situation even with a second dose. In other words, exposed people are still recommending to get antibiotic prophylaxis, and so a second dose would not really prevent any of that based on the information we have. Very hard thing to study about the risk of disease and transmission from a single or two-dose vaccinated healthcare provider versus antibiotic treatment. It's a very complicated issue, but the basic read of it now is that beyond pregnant women, it looks like you're not going to see any recommendation for a booster dose of a revaccination with Tdap coming out of ACIP anytime in the near future. Having said that, and not being a CDC employee, I can tell you that if you only stock Tdap in your clinic and somebody is due for revaccination, the combination vaccine rule that you all know about, I believe still is applicable, i.e. that if a person needs one or more of the antigens but does not necessarily need the third, that in fact it is totally acceptable to use that vaccine if in fact that's all you have, as opposed to missing the opportunity to vaccinate. Wink, wink. So, if you have Tdap and a person is at their decennial, or they had an exposure, and they have a puncture wound, and it's been 5-6 years since their last dose, and all you have is Tdap, you should not hesitate to use Tdap if you do not have TD. And so I think there still is clinician discretion advised. I will tell you off the record, with a camera running, I've had my second dose. So what? I needed it, and there was no TD, so I got a dose of Tdap, and now I have two. So you can use it in your judgment. There's no recommendation, and there's not, meaning it has implications for reimbursement and other things, but it's not likely, based on all the discussions that have been taking place, that you're going to see a revaccination recommendation, even for high-risk folks, anytime in the near future, unfortunately. But we may have actually a license for more than one dose. I believe Sanofi is working on some revaccination revaccination work looking at safety and immunogenicity of second doses in previously vaccinated people. So at least we might have that. I'm not sure that will change ACIP's mind, but it might. It's still expensive. It would be expensive to do.
As a new grandparent, they recommend that we all get Tdap. How often, if you have grandkids every 3 or 4 years, how often do we as grandparents need to be vaccinated?
One time. One time. Current recommendation, everybody needs a dose and a dose only. And there is no, except for pregnant women in their third trimester who get one every third trimester. Because remember, that's not so much about mom, it's about mom's antibodies that get pumped up and get pushed across into the, and that's really important. And that's where, if you pay attention, that's where really the emphasis is now, because there's a kind of a general feel that we clearly don't have the kind of coverage levels we need with Tdap in adolescents and adults, but it is a limited vaccine. The vaccine has probably 5 or 6 years. There's now good data that the immunity wanes after a few years, which begs the question of why we're not giving another dose, but that's another issue. And so the big push now is to try to prevent infant deaths. That's really what the concentration of the thing is, to try to get into the mind of the OBGYNs and the people who deal with pregnant women that a woman needs a dose every third trimester. And that's easier said than done. So anything you can do to try to advance that, because you heard, there's still infants who died in Texas last year and 9 who died around the country, and that's not acceptable. We need to, and I think this does give us a mechanism to try to impact that, even though the vaccine itself could possibly be better.
So a new grandparent got a TD in the ER a month ago for a tetanus-prone wound and now wants a Tdap.
Absolutely. No interval required whenever you have them. Obviously, what's driving that recommendation is the pertussis component, not the TD. So there was a lot of concern about that early on. That's now been looked at fairly thoroughly. There isn't, in theory, because of the boost in antibody, you could have some more local reactions, but currently the recommendation is, and it's been put in black and white now, there is no minimum interval. If a person needs pertussis, they should get it, even if they got it yesterday. What we'd like to do is be able to fix that so they didn't get TD yesterday when they clearly needed Tdap the next day, which means they needed Tdap yesterday too. So that's what we need to try to fix, is that kind of error. But there's no need to wait. If they need it now. Give the Tdap when they need it.
If I could change the subject to a different vaccine.
Your time.
Having just heard Jane and knowing that we originally started with the meningococcal vaccine going into college, and now we're seeing that going into 7th grade, do you anticipate seeing it at a younger age as an initial dose? And second part of the question is, what about those students who are receiving it at a younger age? Let's say 3rd, 4th grade. What would be their interval then going into 7th and going into college?
Well, CDC is on record as saying that basically a dose of meningococcal conjugate vaccine given before age 10 is out of the equation. So it doesn't count. So if they got vaccinated for whatever reason, say they were traveling or outbreak or whatever reason, you should just ignore those doses and give them the 11, 12, and then 16 or 13 and 17, or those 2 doses as adolescents. Without regard to what they got before their 10th birthday. There has been a great deal of discussion about meningococcal vaccination of infants, that they have the highest rates, but there is little, there's not a lot of how can I put this? Even though it's been discussed and everyone agrees that they have the highest rates, all the rates of meningococcal disease are very low now. And it turns out that a routine vaccination program for infants would be astronomically expensive. In other words, the economists won that one too. It would just be too expensive, and the amount of disease that could be prevented, particularly without a B vaccine that could be added to the infant series, is now there are clearly indications for conjugate vaccine, meningococcal vaccine for infants. Traveling outside the United States, international travel to an endemic area, sub-Saharan Africa, for instance, or the Hajj. Children without spleens, functional or otherwise, or anatomic. Children with persistent complement component deficiencies, those are all indications for vaccinating starting at 2 months of age or whenever the condition is identified, and there are 2 vaccines that can be used. One, Menveo brand, is approved for a 4-dose series starting at 2 months of age for children who have an indication. Then Glaxo has a vaccine called Menhibrix, which is different because it's only got 2 components. It's a C and Y, but it has Hib with it, which makes your scheduling situation very simple, right? The problem is Menhibrix is not appropriate for international travelers because it does not contain serogroup A. Serogroup A historically has been the biggest player in Africa in particular, have huge epidemics of serogroup A meningococcal disease in Africa, and Menhibrix is a CY vaccine. In other words, it's basically for people not in Africa because it doesn't contain A. So for travelers, for a child who's being forcibly removed from the country and taken elsewhere by his parents, that child, if it's an infant, they need Menveo. If they're 9 months of age or older, they can receive Menactra, 2 doses of Menactra, but if they're very young infants, Menveo is really the only vaccine appropriate for international travel because it's the only one that's approved for infants, and it has serogroup A in it that will protect the infant against a bad player in Africa.
Is that me? On the new HPV 9 valent, those additional strains, is that going to be the cancer-causing agent that causes the oral, anal, rectal, whatever, all of those additional cancers, or are those typically the strains that only cause the cervical cancer?
Maybe I should go back one step, since you have the benefit of our earlier discussion. As you know, there are 2 HPV vaccines. One is bivalent, contains 16 and 18. Those are the 2 oncogenic strains. That those 2 alone account for 70% of cervical cancer worldwide. Then there's Gardasil, which has those 16 and 18, 70% of oncogenic strains, plus the 2 strains that prevent genital warts. Merck has completed a study now, a very large, very nicely done study of a 9-valent vaccine, and what they've done is they've added 5 additional oncogenic strains, cancer-causing strains, to the original 2, so that the new vaccine that is still unlicensed because the application is pending before FDA. Now the 7 strains in the new vaccine account for 90% of both, I think, cervical cancer worldwide, and certainly a percentage of other site cancers. That's really kind of complicated about which strains affect which kinds of cancers, but certainly it's anal cancers and vaginal cancers and other things. They do contain a portion of it. So it does prevent some additional, well, the thing is, neither vaccine is licensed for actually oropharyngeal cancers because it hasn't clearly been shown yet that the vaccines will prevent oropharyngeal cancers. And that's more of a issue of how the studies have been done, because it's very hard to do a clinical trial with oropharyngeal cancer because there's no pap smear. There's no pap smear or pre-cancer that can be monitored in a trial. And so it's hard to do the trials because you essentially have to wait for the cancer to occur, and that may take 20 years. So the whole thing about, even though people who deal with HPV vaccine agree that well, it prevents infection with 16 and 18 and 31 and 45, and those strains do cause oropharyngeal cancer, so it's logical to assume that they will also help prevent oropharyngeal cancers, even though the clinical trials are extremely difficult to do and may never be done because of the length of, unless somebody comes up with a pap smear equivalent for oropharyngeal cancer. So it has to do with the logistics of clinical trials. That vaccine, the license has been pending with the Food and Drug Administration now for about 6 months, and it could be approved. Merck has presented data on the trial 3 times, 3 different times at ACIP. The vaccine is very, very effective, just like the original quadrivalent vaccine. It has, as you might expect, it has more adjuvant in it because it has 5 additional serotypes, so it has more aluminum adjuvant. So not surprisingly, that's probably what causes a lot, you know what it is, it causes stinging and some local discomfort, and it causes that about the same or more than the original vaccine. But other than that, the vaccine is very safe, is highly effective at preventing even clinical precancers from the 5 new strains. So it could be approved by FDA today, or tomorrow, next week, next month, who knows? They don't tell us anything. They don't tell me anything, certainly. So, but it could come anytime, and ACIP is working now on recommendations so that they can be ready as soon as the vaccine is approved to have guidance for you all to do it. But you should not stop using the quadrivalent or bivalent vaccine that you're using now. You should continue, because we don't know when the new vaccine will be licensed. So continue to press parents on the issue and continue to use the quadrivalent vaccine until we have another.
Would-
Add on to that, do you anticipate there being a need to have that additional dose for those who completed the series of the
She just asked my question.
Yes.
If there going to be a need for a booster.
Well, that's a very good question. And Merck has done one. There is data that has been was presented in June at ACIP. One of their protocols was to take previously vaccinated women and vaccinate them with 3 additional doses of HPV-9, for lack of another name. And they showed that after three additional doses, they respond very nicely to the 5 new components, both women who had never had been vaccinated before or who had been previously vaccinated. What we don't have is incremental data. What they did, the study that they did, they took about 1,000 women and they vaccinated them 3 times. They drew blood after a month after their first dose and a month after their last dose. And so they have 2 points in time after 1 additional dose and after 3 additional doses. And clearly they had lots and lots of antibody after 3 additional doses. What we don't have is 2 or 1, and what we do not have is mixed schedules of, say, 1 dose of quadrivalent and 2 doses of 9-valent, or 2 and 1, or some other combination. There is none of that. So the work group is aware that there's going to be a lot of interest. I mean, we're talking about 20% additional coverage for oncogenic strains. That, to me, is a worthwhile thing to want to prevent, and I think you would agree. But the question will be exactly how will that be framed by ACIP, because their presentation that they made in last week in Atlanta was that their main concentration is going to continue to be to improve basic 3-dose coverage levels rather than spend a lot of effort and resources on revaccination of people who have already gotten a 4-dose series. But I think it is incumbent upon them, and they intend to add some kind of guidance to summarize this study that Merck did. And likely what will come from that is some kind of permissive recommendation that if a person wishes to have additional coverage for the 5 strains in there, that additional vaccination is needed, and it will probably be 3 additional doses. I'm guessing. I've not seen anything. Nothing's been approved. They've not given us the final versions, but they're going to address it. What we won't know anything about is what about mixed schedules? What happens if you get 2 of one and 1 of the other? If you only get, for instance, if you get 2 quadrivalent and 1 9-valent, that means you get 3 doses of 16 and 18, but you only get 1 dose of the new 5 ones, of the 5. And is that enough to assure the person is immune to the 5 strains, or is it going to require 3 doses of non-valent, regardless of the number of doses you got before? So all these are still up in the air. There's a knowledge that this needs to be addressed, and I think we'll see it forthcoming once the vaccine is licensed.
What about using it over the age of 26?
What about using it over the age of 26? Well, CDC is already on record as saying that if an individual began the series at 26 years of age or younger, that it should be completed at whatever age the person currently is. In other words, to continue the series even if they're 27 or 28 or 29. The issue comes as to whether or not you should start vaccination when the person is 27 or older. And there are some data. Merck did a study with older women and showed the vaccine is safe, but had more difficulty in showing that it was effective because of some issues of finding women who had never been infected before. And so it was kind of an issue with the way the trial was done and the number of women who were in the trial. So there's data on safety, and it's clearly a safe vaccine through age 45, which is where that study was done. What should you do? ACIP is silent on that, but having sat through a lot of ACIP meetings, they've said before that they are not the vaccine police. CDC is not the vaccine police. ACIP is not the vaccine police, and have kind of have basically taken the FDA has taken the position that if, in the opinion of the clinician and the patient, if you have a discussion, say this is you have a 30-year-old who for some reason is being exposed now to HPV and was not previously, or forgot or didn't get around to it, and she or he asks for the vaccine, you point out it's not approved for that by FDA, there's no recommendation, but there's no safety concern. The vaccine is a safe vaccine, it's an inactivated vaccine. The data on prevention is less good because of the way the trials were done. And if you decide it's in the patient's best interest, you can certainly give them that vaccine off-label. What the problem you'll run into is the fact that if it's given outside the recommended range, you likely will get pushback from the payer, because they tend to align themselves along with ACIP recommendations, since they may deny payment if you give it to a person age 27 or older. However, I would point out that a $500 series of HPV vaccine is probably cheaper than a single colposcopy, or certainly any kind of other invasive procedure that a woman might need because of a workup of an abnormal pap smear. So you can certainly do that. It's not something that's in the recommendations, but again, if in your opinion the vaccine is beneficial and the patient understands it's off-label and wants to have it, you are free to use that vaccine in your clinical judgment. Particularly when there's not really any safety issues. You know, if it was one thing, you get to be 28 and suddenly people have seizures and strokes, then that's one thing, but that's not the issue here at all. The vaccine is extremely safe, and there's safety data that goes clear to age 45, and it's not an issue.
I have a question that keeps coming up about Proquad versus doing the initial varicella and MMR separately. What's the opinion on that?
Well,
For first round.
for those of you who aren't familiar with that nuance, it all had to do with febrile seizures, and it has to do with the fact probably that there's a lot more varicella vaccine and more fever that happens with MMR-V than with MMR and varicella separate, probably because of the amount of varicella vaccine that's contained in the MMR-V, which is substantially more than in a regular dose because of the competition when you put them together in the same syringe. ACIP has basically stated a preference for using them separate because and off the top of my head, it was something like one additional febrile seizure for every 1,500 or 2,000 doses of MMR-V. So it's not huge, and febrile seizures, of course, are not something that causes brain damage or causes any kind of permanent disability, but it freaks parents out big time. And so in order to reduce that risk of febrile seizure, which admittedly you could give MMR-V for years and not ever see a single febrile seizure as a result of it, but to err on the conservative side, ACIP has, as a general rule, stated, actually the CDC stated the preference to use MMR and varicella separately as the first dose. Again, the probability of having a febrile seizure is fairly small if the patient, and so it's something that should be discussed with the parent. You know, if they'd rather have just one shot, given that there's a small chance he's liable to have a fever, more likely to have a fever, and hence possibly might have a febrile seizure, if they're all right with that and would rather bet that against 2 needle sticks. So it's a matter of how you sort of relatively compare those two issues about 2 shots versus 1 versus a small increase in risk of febrile seizures a week or so after the vaccine.
For the 4-year-old?
4 years is not an issue at all.
It's not an issue at all.
It's only the first dose in children younger than 2 years. So it's basically only the first dose given in completely susceptible kids, right? Vast majority will respond after the first dose. The second dose is really that insurance to make sure that last 2 or 3% respond. So it's not an issue for age 4. In fact, it's preferable to do it then because you do save a dose. You save a shot at age 4. It's the first dose given to susceptible young children is the issue.
So can rotavirus vaccine be given in the hospital to some of these very low birth weight infants who are still 2 months old and in the hospital? Because a lot of them end up not getting it in the hospital because of fear of, rotavirus vaccine in the stool, contaminating the environment, and then they're too old once they finally get to go home.
I think ACIP hasn't really still kind of generally says it should be avoided in hospital settings for that main concern. But I believe that there's been some data now generated that the risk of transmission, even in an ICU situation, is very small. And so overall, the benefit and risk probably falls on the side of the benefit of vaccinating the child in the hospital, given that I think in pediatric intensive care and pediatric settings that people are aware of the possibility of transmission, and you do experience stool contamination of the environment, and people know how to deal with that. So I think in the long space of things that probably the giving the vaccine in the hospital setting, if it looks like the child is going to age out, because that seems to be the more important thing, because then that increases the risk perhaps of intussusception. So the benefit probably is of vaccinating the child in the hospital while they're still age eligible, as opposed to letting them age out and basically getting no vaccine at all. And so I think in the risk and benefit balance, I think probably the benefit would be to vaccinate the child and be aware that it happened and take appropriate precautions, which I think is certainly feasible in a hospital setting.
Thank you. Other questions? We have about 8 more minutes.
In light of the, resurgence of measles, for your adult patient vaccination, if they were born in or after 1957, and they've said they've, gone through high school in Texas when all the vaccines were recommended and blah, 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 but they don't have a documented case, do you just say, give it to them,
Yes.
right?
Yes.
Yeah.
Yes. And because I think I was in Texas when they were recommending the vaccine or required the vaccine is not sufficient evidence. If they can't show you documentation of having gotten it, they should get a dose. Everybody needs a dose or some other evidence of them. That's unfortunately we invariably in the outbreaks, including the current one, we see people who are born before 57 who get it, and older adults who thought they got it but they're not. They didn't get it. So yes, everybody deserves a dose of MMR to make sure that you're immune, and if you are high risk, like all of you by definition are, or traveling outside the country, you need documented doses or other evidence of immunity.
How much of a local outbreak would it require before we'd start doing 6-month-old MMRs? With all these importations, it's
Good
made
question.
me wonder.
I think that would kind of depend on the nature of the outbreak in general. Because what we've seen lately, and Dr. Hinman might want to comment on that, seeing how he did a breakout of this, a break-in, I guess we're calling them. I think in general that given that it's a safe procedure, that you would have a relatively low threshold for going to 6 months. But again, if there were if the outbreak was primarily concentrated in people who were exempt for one reason or another, it was mostly happening in adults and older children, which is commonly the case in school settings. There's no harm in vaccinating. If you've got young children in those environments, it certainly is not going to hurt to give them a dose. But I think as a matter of routine and doing that as a policy in an area, you would probably need a pretty good size. You'd need good evidence that there was really transmission among preschool age children before you'd really make a policy and start vaccinating a lot of infants. But certainly on a case-by-case basis, if there's one 8-month-old in a household that had measles in the household, I think it would be worthwhile to do it in that situation. Any thoughts?
I agree. It's okay to vaccinate infants as young as 6 months.
Yep.
You just can't be that confident that they will be protected.
Right.
So you're going to want to be sure that that you give them 2 more doses of measles vaccine after they pass 1 year of age. But I agree also that this is not going to come up as a very common situation. I think we really need to be evidence that infants less than a year of age were at significant risk.
Yeah, that really hasn't been the demographic of outbreaks recently. As far as making a policy and making a kind of a blank recommendations to routinely reduce the age to 6 months. So we haven't come to that. Fortunately, we've still got measles. It still is those annoying importations and transmission around those.
Right. And on the other hand, if parents were going to take a 7-month-old to the Philippines, I would recommend that they have that child vaccinated against measles.
And that's probably a part of our measles control strategy. Probably the part that's being missed the most is the fact that if you do have any access to children being taken internet, and I think I would not even limit it to the Philippines, pretty much any place outside the United States, I think you should recommend that the children younger than a year get a dose of MMR before they leave.
Any chance that CDC or ACIP can get the airline companies to print that on their electronic tickets?
Not really likely.
No, I'd say.
We
Not
have
likely.
talked with airline companies, now we're talking 30 years ago, but they are not in the health business, they say. And they also are concerned about liability they might incur if they are seen as essentially practicing medicine. So I don't think it's highly likely.
But they have been quasi-helpful in as far as notices and notifications and things of that nature. So they haven't completely divorced themselves from it, but you're right. That's about as far as it'll go.
Well, I think our time is up, and we've not been getting our full break time between sessions, so I'm going to allow anybody who's
Because
ready to leave.
I think the final
and-
session today is about pertussis, so I think you'll
That's
probably
right.
want to be there for that. So.
That's right. Thank you.